In this video, dissection of the arm will be demonstrated. This work was produced by Dr. Carlos Andres Suarez-Quian and Dr. Joel Valensky. Dr. Suarez-Quian is the narrator of this video. Anatomically speaking, the arm is located between the shoulder and the elbow. If you break your arm, you have broken only one bone, the humerus. There's nothing funny about that, albeit it is called the funny bone, the humeral bone. Let's start the dissection of the arm. Before starting, orient yourself. This is the left arm in the anatomical position. The thumb is on the lateral aspect of the arm on the top of the slide, whereas the little finger is on the medial aspect of the arm at the bottom of the slide. After removal of the skin of the anterior aspect of the arm, scattered fat deposits within the superficial fascia and cutaneous arteries and nerves that travel within this layer become apparent. Note especially the medial cubital vein and the aponeurotic insertion of the biceps brachii muscle into the ulna. Further, note that whereas the medial cubital vein passes superficial to the bicipital aponeurosis, the brachial artery passes deep to it. The artery is also accompanied by the median nerve at this point. Why is this relationship important? The aponeurosis acts to cover the brachial artery and thereby minimizes the risk an agent accidentally is injected into this artery instead of the vein. The French even call this aponeurosis grâce de Dieu, or grace of God, for how important this aponeurosis is in protecting the artery and nerve from injury. However, in about 10% of people, the artery also runs superficial to this aponeurosis. Thus, before making an IV injection that is meant for the vein, what could the clinician do to ensure that they indeed have identified the vein and not an aberrant brachial artery? Feel for a pulse. If a pulse is present, they do not inject into the artery. The reason that this could have serious consequences is that some agents, especially chemotherapeutic agents, need to be diluted before reaching critical structures. This naturally occurs when such an agent is injected into a vein because the blood flows proximally towards the heart. In contrast, such an agent injected into the brachial artery does not get very diluted before reaching the delicate nerves of the fingers because arterial blood flows distally. In one well-known case, a guitar player lost the use of his hand because the resident physician injected into the brachial artery instead of the vein. The biceps brachii is well encased by deep fascia. Note that the medial components of the brachial plexus are located just posterior to the short head of the biceps brachii and can be palpated there along with the brachial artery, which is partially hidden in this view. The median nerve is labeled for orientation of this area. Note the medial antebrachial cutaneous nerve, which supplies the skin of the medial side of the forearm. This nerve can be large, and students sometimes mistake it for the ulnar nerve, which, as you can see, passes deeply into the triceps brachii to reach its canal posterior to the medial epicondyle of the distal humerus. The medial antebrachial cutaneous nerve is strictly sensory, and because it serves a large area of skin, this skin flap is now frequently used in reconstructive procedures by plastic surgeons. Once the deep fascia is removed, the two heads of the biceps brachii come into view. Remember that the lateral head is the head that represents the long head. Again, the lateral head is the head that represents the long head of the biceps brachii. The brachialis muscle, which is the primary flexor muscle of the elbow, lies deeply to the biceps brachii, and the coracobrachialis lies medial to the short head of the biceps brachii, having a similar origin to it on the coracoid process of the scapula. The musculocutaneous nerve, which innervates all three of the muscles we have just mentioned, pierces the coracobrachialis and runs between the biceps brachii and brachialis muscles. Surprisingly, however, it continues into the forearm, but not as a motor nerve, rather as a purely sensory nerve that is now called the lateral antebrachial cutaneous nerve, or lateral cutaneous nerve of the forearm. This is somewhat analogous to a street that changes names between one corner and the next. Similar to nerves, arteries also undergo name changes. So here we see the axillary artery, a continuation of the subclavian artery. But once the axillary artery crosses the teres major, it becomes a brachial artery and continues as such until reaching the elbow. We will see that it will then divide into a radial and an ulnar artery. We begin the process of dissection of the posterior arm by skin removal and preservation, if possible, of cutaneous structures such as the cephalic vein, which is again seen here. With complete removal of the skin, we of course see superficial and deep fascia, and we also again see the lateral antebrachial cutaneous nerve running with the cephalic vein. The triceps brachii is the muscle of the posterior arm. It acts to extend the elbow and is innervated by the radial nerve. In this view, we see two of its heads, the lateral and the long heads of the triceps brachii. The long head attaches to the scapula in between the teres minor and teres major, a dead giveaway that this is the long head. We are able to show this relationship because the posterior deltoid was reflected previously when we dissected the shoulder. The axillary and radial nerves are branches of the posterior cord of the brachial plexus. The former is found by reflecting the deltoid muscle in an area called the quadrangular space that we showed previously when we dissected the shoulder region. Whereas the upper part of the radial nerve is found by manually separating the long and lateral heads of the triceps to reveal the nerve in a region that is called the triangular space. The radial nerve is followed distally by further separating and reflecting some of the fibers of the long and lateral heads of the triceps. Note here how the nerve is intimately related to the posterior surface of the humerus. This relationship explains why a fracture of the shaft of the humerus often is accompanied by damage to the nerve and the manifestation of a wrist drop condition. The medial head of the triceps is revealed by reflecting the lateral head still further. The medial head arises from the posterior surface of the humerus, distal to the origin of the lateral head, and joins with the partially fused fibers of the long and lateral heads. As the elbow is approached, the radial nerves moves laterally to enter the forearm. The anconeus is a small muscle that acts with the triceps brachii during elbow extension to provide some stabilization to the elbow joint. Note the very strong fibrous insertion of the triceps into the olecranon process of the elbow. This now concludes the presentation on the arm.